I'm Sanjeev Bhalla, and I'm the Section Chief of Cardiothoracic Imaging here at WashU in St. Louis, Missouri. So I think we have all become pretty familiar with the idea that pulmonary embolism protocol and CT is a great way to diagnose bland thromboembolic disease to the chest. The spatial resolution of CT, the speed of CT allows for the diagnosis to be readily made. One of the confounders, however, is that if we have a large mass present, that whether or not the embolic disease is bland or if it is potentially related to the tumor. In other words, are there tumor is there a tumor that's embolized to the lungs? That could be a very hard thing to appreciate when you first see filling defects. One of the things that we find very helpful in this case, for example, where you can see that there's a large renal mass. In this case, this was a Wilms tumor in a child. We saw that there were filling defects that were present within the pulmonary arteries, but we'd like to point out that there are areas of enhancement. So bland thrombus should not enhance. And if we see areas that enhance, then it should really raise the question of whether there can be embolic disease to the pulmonary arteries. Now, the classic characters that are known for metastasizing to the chest via embolic disease to the pulmonary arteries in the adult include hepatocellular carcinoma, adrenal cortical carcinoma, and renal cell carcinoma. Occasionally, we'll see uterine neoplasms metastasize in this fashion as well, but those are much less common. In children, a Wilms tumor is much more likely to do this as compared to a neuroblastoma. So when we see that, we can make that comparison as well. So it's very useful to look for this enhancement to make that distinction. In the second case, we have a patient who's an adult who also had a embolic disease to the pulmonary arteries. And here we can see that there are areas of enhancement. Looks very similar to the subcarinal lymph node. It looks very similar to the patient's parent tumor, which was hepatocellular carcinoma. A good reminder that hepatocellular carcinoma can embolize to the pulmonary arteries, and these intra-arterial metastases can enhance. They tend to look very similar to the parent tumor. Now, occasionally, you'll see bland tumor that is associated with this tumor that's embolized, I'm sorry, bland embolism that has that is on top of the tumor embolism, and that's probably some in situ thrombus that's formed. So it's not uncommon to have a part of the embolic phenomenon that doesn't enhance and a part that does enhance. So we always look for areas that are just, even if a portion is enhancing, we get concerned that we're dealing with a embolic tumor to the pulmonary arteries. And in this case, again, this was hepatocellular carcinoma. Now, what is, I think, confounding to many of us, and something that it took us a while to understand, but I want to share with you, is that occasionally the metastatic disease to the pulmonary arteries doesn't lodge with a macroscopic filling defect within the main pulmonary artery, but instead we get microembolic disease that deposits in the small arterioles of the lung. This is such an example where a patient who presented with colon cancer had developed, it was a high grade colon cancer, and the colon cancer had metastasized to the pleura. We could see that there's some enhancement of the pleura with a pleural effusion. But what was very nefarious in this condition was that the lungs were showered with tumor microembolic disease. We saw no filling defects on the soft tissue windows, but instead, what we saw was that there were vessels that are normally not seen on the CT. Normally, these vessels are too small to be seen this far peripherally, but these vessels are engorged with tumor, and as a result, you can follow them almost all the way to the pleural surface. You know that they're vascular because they're branching, and there's no air trapping to suggest that it's an airway that's filled. What can also be useful is sometimes to look at the right heart. In this case, the right heart was not that enlarged, but this patient very quickly developed an acute pulmonary hypertension and eventually had expired from this embolic disease. So one of the things that we always try to look out for, in addition to lymphangitic carcinomatosis, which would be hematogenic spread to the lymphatics, is to look for this appearance of these kind of branching small vessels that may represent a microembolic disease. These patients usually are very symptomatic, And so discussions with our medical oncologist or radiation oncologist or surgeon usually allow for the diagnosis to be achieved. But I do want to draw the attention to this finding because this finding is kind of subtle and sometimes easily overlooked because you don't see the discrete nodules that we think of with metastatic disease, nor do you see those macroscopic filling defects as we saw with those first two cases that are a little bit more obvious. Now, occasionally, you'll have a filling defect and you're not sure. You're not sure whether this is a person who's got metastatic disease or is this bland embolic disease. We were suspicious because there were some areas that looked like they were enhancing. Now, in those patients, it can be very useful to do either an FDG PET CT. This was a slightly older case, so you can see that the PET portion was not co-registered with the CT, but you can see that there's increased uptake. A bland embolism should not have increased uptake. And so if you see that uptake within the embolism, it suggests that it's a tumor origin, potentially. Very rarely, histoplasmosis or some fungal infections can involve the pulmonary artery and can have uptake. But in the right setting, it becomes very concerning that this is metastatic disease. Another option, of course, is MRI, that increasingly MRI with contrast can be very useful as well. So our concern when we are seeing a patient who is a patient with a history of neoplasm, when we see a filling defect that is just classic thromboembolic disease, we expect it to be low attenuating without enhancement. If we see anything that looks like enhancement, our antennas go up that there could be potentially tumor emboli, and then we have to start considering whether or not there's role for doing either a PET CT or to do an MRI to help confirm the diagnosis. Very rarely is biopsy performed in these patients because it's invasive and usually it's not needed to make the diagnosis. I will tell you that with the tumor microemboli that we saw, it's unusual to see any macroscopic filling defect. The key there is to look on the lung windows. So in short, this case just illustrates that there is enhancement of filling defects within the pulmonary arteries. That enhancement suggests that this is a metastatic tumor emboli and not bland thrombus. A reminder, bland thrombus should not enhance. If we see enhancement, especially when it follows the parent tumor, that's really a very good finding for macroscopic tumor embolic disease. Again, enhancement should not be seen with bland thrombi. Now, occasionally there will be microscopic tumor emboli to the lungs. Those will be picked up, as in this case, with branching structures that are best seen on our lung windows, as we see here. And occasionally you may see other findings of metastatic disease, including malignant pleural effusion or lymphadenopathy, but those aren't required. These patients tend to be very profoundly symptomatic. And finally, if you have a filling defect that you're concerned could represent tumor embolic disease, a reminder that this is a great time for consideration of FDG PET, which may show uptake in tumor embolic disease, or MRI, which can show that there's contrast enhancement in that embolism, which would be very typical of a tumor embolism.